Welcome back. I hope you're feeling energized as we still have a lot more expertise to share with you. It's great to see you all getting involved in what the platform has to offer. All the content from today will be available to view on demand within 24 to 48 hours. So don't worry if you've missed something earlier, as we all know how busy healthcare is at the best of times, let alone over the last 18 months. So let's start our afternoon with a panel discussion focusing on decarbonising medicine. The coronavirus pandemic gave us a glimpse of something important, improving our air quality. Climate massively impacts our health, and as an NHS, the commitment to positively transform our services has been recognised. Within pharma areas identified for development are production and waste processes in medicine. Additionally, integral changes are to optimise prescriptions, substituting high carbon products for low carbon equivalents. Well, here to discuss this with me, we've got a brilliantly suited panel. We're hoping that Dr. Lucy Brooks, Leadership Fellow in Climate Change and Anaesthesia, will join us very shortly. We've got Dr. Sam Hugh from the University of Exeter, Dr. Tom Pearce, Cardiac Anaesthetist at University Hospital Southampton, an environmental advisor to the President Royal College of Anaesthetists, Dr. Marcia Philbin, Chief Executive, Faculty of Pharmaceutical Medicine, and Dr. Thomas Daniels, Consultant Cystic Fibrosis and Respiratory Physician, Clinical Lead for Environmental Sustainability at University Hospital Southampton. I managed to do that and keep my teeth in. That was quite impressive with all those very long names there. Now, do remember this is your opportunity to ask any questions you have of our panellists, and what a privilege it is to have 5 doctors with us. So if you do have a question, use our live Q&A function on the right-hand side of your screen, and I'll get to as many as them as possible. Welcome, panellists. I hope I'm just looking at the screen there. I think we're hoping that Lucy's going to join us shortly. But Sam, if we can start off with you. I've been quite fascinated reading about your research and what's been going on with the theatre teams trying to capture and recycle anaesthetic gases that are used, obviously, to put people to sleep. Can you just explain a bit about that research and what's been going on?
Yeah, sure. Hello, everyone. Thanks for here. So about the study that we did on anesthetic gases, after working with a local startup, Cystic Medical, who are absolutely brilliant and enthusiastic to recycle and reuse the wasted anesthetic gases, we have estimated the carbon footprint of each anesthetic gas throughout its life cycle under various scenarios. And the scenarios we modeled vary by the manufacturing processes used in the industry, gas consumption rates, and the application of a vapor capture technology. What we find is that the greenhouse gas emissions generated during manufacturing vary significantly depending on how these drugs are synthesized. And B, using the 2018 NHS anesthetic gas consumption data, we find that the carbon footprint of used sevoflurane can be as large as desflurane in some scenarios. And I think for the audience here, I suppose that I don't have to introduce you about desflurane, which we all know is the worst gas in house due to its extensive global warming potential. So these findings suggest that to reduce the carbon emissions of anesthetic gases used in the NHS, it's not just by simply replacing one, such as desflurane, with the other, like sevoflurane in practice. Knowing how the drug is produced and its associated emission is also crucial. Given the complexity of manufacturing and administering the drugs, more effort should be made to create a system that can continuously monitor the environmental impact of the drugs used in the NHS. And the other significant finding I think is worth to highlight is with the help of Cystic's vapor capture technology, the carbon footprint of sevoflurane can be as low as its counterpart anesthesia propofol, which is in general considered as the most environmentally sustainable anesthesia, while keep in mind that propofol can, in addition, cause other downstream harms to our environment, since it's toxic to aquatic organisms.
Gosh, that's a very sort of detailed explanation, or clear explanation rather. And when reading that research, I didn't have any idea that such a small amount of anaesthetic is actually absorbed by the patient. But Tom, anaesthesia seems to have led the field in sustainable practice. Obviously, following on from what Sam said, some of it's obvious why, but why is this?
To be truthful, the thanks has to go to the foresight of one of the presidents of the Royal College of Anaesthetists. He was always known by his initials, JP van Beschow, who was, as president, created for the very first time the position of environmental advisor. This followed the publication of a number of articles that really drew for the very first time the importance of volatile anesthetic agents. That's to say, the drugs that Sam's just described, sevoflurane and desflurane, the importance of those in the carbon footprint of healthcare delivery. So the thanks really has to go to him. I was the fortunate soul who took on that mantle, and it was really very much an educational role. Educational both in literature, educational as in lectures and presentations, but educational in almost departmental analysis of what individual departments are doing and where they can make a difference.
Thomas, are place to be leaders in climate change?
So, if that was for me, thank you for that. Yes, I think as healthcare professionals, we have a key role in helping reduce carbon emissions, and I see the roles threefold really. The first is taking personal actions, and perhaps this isn't the place to be talking about those, but I think they're still important, both as role models and for the effect they have themselves. I think the second area that we need to show leadership is in rather than sort of downward pressure on our own emissions, sort of horizontal pressure, as I would describe it, on our colleagues and our teammates around us, encouraging sustainable QI projects and raising the issue wherever and whenever possible. And thirdly, I think we have a role to play in upward pressure on those above us who are the leaders or the more senior leaders in our organisations, and those organisations are manifold really, both in our royal colleges, if one has one of those, or through the GMC, or through one's own subspecialist professional body, and raising the issues and making sure that those organisations are taking this as seriously as the emergency that it is really important. They don't hear much from their members, and when they do hear from their members, they sit up and pay attention. So I think there's a lot to be said for that. And finally, within our own organisations, we need to make sure each hospital is taking this seriously and embedding sustainability in its everyday practices.
Lucy, I'm glad that you've popped up now on our screens. I'm just going to talk to Marcia first, but I have noticed that you're there now, so I'm pleased that you've been able to join us. Marcia,
hi.
Just you were making copious notes there, so reaction to the panelists have said, but also can you just explain a bit about the Faculty of Pharmaceutical Medicine and your perspective in decarbonising medicine?
Yes, so thank you for allowing me to be here. So the Faculty of Pharmaceutical Medicine is the membership body for doctors who are involved in all aspects of medicine development. Our doctors are involved in clinical trials, they're involved in regulatory activities for the ethics approval of clinical research. And most of our members, I would say, probably work in industry, whether that be in pharmaceutical organisations, in biotech, as well as in the NHS and regulatory bodies. FPM is exploring how the research community can take steps to decarbonise the production, transport, use and disposal of medicinal products. And at the height of the pandemic last year, FPM surveyed its members on the robustness of clinical trials during and after the COVID-19 pandemic. And what it revealed was really interesting. Sometimes it takes an emergency to force innovation and change behaviour. And with the COVID-19 crisis, what we saw was quick decision making and leadership allowing or supporting new ways of doing things. So our members gave examples of the innovations that took place to allow clinical trials to continue. For example, the remote monitoring of subjects in their home environment rather than subjects traveling to clinical trial sites. That was something that didn't really happen before, but because of the COVID-19 crisis, this is something that is now happening and is likely to continue after the COVID-19 crisis abates.
I think there'll be a lot of people nodding their heads in our audience as well as on our panel with what you're saying, Marcia. And we host a lot of conferences like this in various industries, including the rail industry and public sector. And I think a lot of people are taking positives from the pandemic and how it's made us be more aware of things we need to just get on with. Lucy, I'm aware now that I haven't spoken to you at all. So how can we encourage anaesthetists to make less environmentally harmful choices? And can you talk to us a little bit about whether we should stop procuring desflurane, which I think Sam mentioned in his first answer?
Yes, thanks for having me. Sorry for missing the first couple of chats. I had some technical difficulties. So in terms of what we can do to help anaesthetists make more sustainable choices, well, I think we need to making the sustainable choices as easy as possible. I'm doing some research at the moment in a large teaching hospital in Yorkshire, and we've asked anaesthetists about whether or not environmental sustainability influences their decision making in terms of their anaesthetic choices. And it does. 96% of people who responded to us had told us that the environmental sustainability impacts to at least some degree affect the amount or the choice and the amount of volatile anaesthetics they use. So we know that doctors are already thinking about these things and wanting to make sustainable choices. So how do we make doing the green thing easy? I mean, that might be removing desflurane vaporizers from the back bar, or to stop procuring it altogether, which I will talk about in a minute. But it also means making other things, so alternatives to volatile anaesthetics, more easy. So things like having enough equipment to provide total intravenous anaesthesia was seen as a major barrier to being able to use that as a viable alternative in clinical practice, just simply because there's not enough kit or it takes too long to find it. So it may be that as a trust you could audit how much this equipment you have and how often it's used, and see if there are ways of sort of combining it in a hub, for example, a total IV anaesthetic hub, so people could charge all the devices overnight and go and get them and know exactly where they are first thing in the morning. And when we're talking about sustainable choices, I don't think it's just about using less anaesthetic gases. All these other things that we do also have trade-offs. Using more intravenous anaesthetics, there's increased drug waste, and we need to make it easy for people to dispose of their waste properly and educate them so they don't just pour drugs down the sink. And making recycling facilities available for packaging and equipment at the point of use. And when it comes to stopping procuring desflurane, I definitely think that's what we should be doing. It's much more expensive and significantly more costly to the environment as a greenhouse gas than other clinically viable alternatives like sevoflurane. And as I say, it's a lot more expensive because it's less potent. We have to use 3 times as much of it. So for every £1 you spend on sevoflurane, you're spending £4.86 on desflurane to get the same clinical benefit. Plus, you have the additional 60 to 70-fold worse toxicity to the environment with DES than you do with Sevo. So whilst I know there is some pushback about individual anaesthetist autonomy, ultimately, I think we need to take a bigger picture view here and recognise that money could be spent on better things in healthcare and more innovation. And actually, that a lot of anaesthetists are on this journey already. The majority of anaesthetists in the trust where I work are already saying that they're not using it. So I think we'd be pushing against an open door with that one.
Tom, pushing at an open door?
I think the door has been open for a while, in truth. When I saw the GERFT data, that stands for Get It Right First Time. This data was made available about a year or 18 months ago, and it was before the COVID. Before COVID, and it showed a very significant fall in the national use of desflurane across the country. And I think that door has been opened, and there's a huge reduction. It has to be said, though, and Lucy has introduced the subject already of equipment and choice in anaesthesia. I think it's fair to say that anaesthesia machine developments and For example, things like the development of end tidal control have been able to reduce our volatile anesthetic use even further for in those instances where there is good clinical indication to continue to use drugs such as desflurane.
Sam, I'd like to bring you in too with your sort of reaction to that. I think you looked like you were agreeing with what Tom said, but also off the back of it, I'd love to talk to you about what the anaesthetic company does in terms of recycling the gases. Lucy mentioned packages and equipment, but the gases. So it's a bit of a badly phrased question, twofold, bit of a reaction to Lucy and Tom's thoughts there, and then a bit about recycling of the gases, if you would.
Yeah, I think I can't say because I'm not working for the company, so I can't say much about the company itself. The only data that I knew from this company is that their recycling rate is roughly 70% before the pandemic. So we have used that in our scenario models and estimated the carbon footprint of sevoflurane can be brought down to almost the same low level as propofol. And they were aiming to trying to increase somewhere above 90%, but I'm not sure where is their progress right now. And also I think from my knowledge that their machines are all built by 3D printing and using green kind of materials. So in that sense, it's from the starting of their production process, they have put the environment into their head, and I think they're trying their best to minimize their environmental footprint.
Thomas, what do you consider the barriers to onward decarbonisation?
Yeah, so I think I'd like to make 2 points. Firstly, for all of us clinicians who interact with pharmaceutical companies, I think there's a lot to be said for raising the issues of sustainability when we have conversations with them. I've been doing that over the last 6 to 12 months, and I've been surprised by how welcoming pharmaceutical representatives are to those conversations. And those companies who have made big strides, and I note Chiesi and AZ, AstraZeneca as two companies that seem to have done some interesting stuff around sustainability recently, are very open to that and really keen to tell you about their achievements. And for those companies that are perhaps not doing so much, it perhaps nudges them in the right direction. So that's something that's very simple and easy for all of us to do in our day-to-day interactions with pharmaceutical reps. And the second point I thought was worth making is that we've heard a lot about anesthetic gases. I'm a respiratory physician, and respiratory also has a very large carbon footprint through the propellant gases that are in the pressurized metered dose inhalers that patients with respiratory illnesses use so much of. Surprisingly, those propellant gases contribute an awful lot to global warming. The propellant gases are somewhere between 1,000 and 3,000 times more global warming potential than per molecule than carbon dioxide. And when you add up all the inhalers used across the whole of the NHS, they contribute somewhere around 3.5% of the entire carbon footprint, which, given that it's just one type of medicine in a huge organization, is very disproportionate. And there's lots that we can do to reduce that carbon footprint. As many of you will know, there are many different types of inhalers, dry powder inhalers and soft mist inhalers, that don't have that same propellant in them and therefore are intrinsically less polluting to the environment. And so my approach is to gently raise the issue with patients and just explain that we know and understand a bit more about it, and is that something that they'd be keen to do something about. And I'm always very surprised how welcoming patients are about the idea that they could do something to help the environment. People will often feel so disempowered and helpless in the face of such a massive crisis. And for them to feel that there's something that they can do, most patients are very welcoming of that. And there are simple things they can do, like if they use the metered dose inhalers, return them to be disposed of at chemists, therefore not releasing the remaining propellant into the environment so that they can be incinerated. Making sure that patients are taking the minimum number of puffs, i.e. maximizing the strength of the inhaler. So instead of 2 puffs twice a day, double the strength of it and take 1 puff twice a day, immediately halves the carbon footprint. and then considering whether an MDI type inhaler is the best inhaler for them. Could they be as good, if not better, on a dry powder inhaler or a soft mist? And by doing this, and particularly by focusing on the high users of MDIs, usually salbutamol, you can achieve a triple win, really. Those patients using lots of salbutamol inhaler are frequently the patients with worse disease control. So if you focus on them and improve their disease control, you're helping them feel better. You're reducing their admissions into hospital. You're reducing their salbutamol inhaler use and therefore their carbon footprint. And frequently you're saving money as well. So just with some really simple steps and focusing in on things that perhaps people historically don't focus on enough, you can have a really big impact on patient care, on costs, and on the planet. So I think that's something that there's a lot of low-hanging fruit among the respiratory community and primary care community to be had there.
Just really briefly, Thomas, just following on from that, is that message getting through to people who use inhalers? Has there been sort of a big campaign to let people know? Because it's not that I use an inhaler, but it's not something I'd ever heard before, and that's extraordinary.
It is extraordinary. There has been a little bit of news about it. Unfortunately, it was not handled very well, and there was a little bit of a backlash in as much as it was reported in the press as inhalers are killing the planet. And so the natural response from patients to that is, oh, I'm going to stop my inhalers, which is obviously the wrong thing to do. So and I think some people may have come to some harm as a result of that. So it needs to be really carefully managed. And my practice is to bring it up in consultations in a gentle way, focusing on the fact that they mustn't stop their inhalers. Don't do that. It's much more important they stay healthy. And then gently introducing those other, changing the strength of the inhaler, considering other inhaler devices, but really making sure they don't just suddenly stop their inhalers, because that would be obviously the worst thing possible. But overall, I think the answer to your question is no, that message is not getting out there enough.
Sorry, I thought you'd finished there.
I've got one other thing to say that people might be interested in, is if they want to know more about that and take part in a national audit that's currently being planned. I see that the Centre for Sustainable Healthcare on the Respiratory Medicines Forum there is some information about a national audit that's being planned, so around sustainability of inhalers. So people might want to get involved with that.
Cool. Gosh, there's so much I want to ask. I want to in a minute get on to Tom's app, so that's coming very shortly. But Marcia, just bringing you back into the conversation with your chemical research background, what do you see as the challenges ahead? And then I'd like to ask you the same question, Sam, in terms of the challenging factors for academics. So I'll give you a chance to think about that while I hear your answers.
Yes, so traditional medicines are made using the principles of organic chemistry. So you need a solvent in which your reaction takes place, a catalyst to speed up the reaction, and the right conditions such as temperature and pressure. And the biggest waste in organic synthesis is the volume of solvent that's used. 80% is wasted. So by redesigning the synthesis, you'll help to reduce the organic waste significantly. The other thing about organic waste is that it is toxic and it can be difficult to dispose of. So if you can redesign synthesis to use less solvent, and Pfizer has achieved this with its blockbuster drug, for example, Lipitor, it reduced the amount of solvent used by 65%. Catalysts used tend to be based on transition metals such as palladium, and these are also toxic as well as expensive. And what's coming more and more to the fore is how these metals are mined and the impact it's having on the local environment, and also for the people who are involved in those areas, because they tend to come from the global south. So as well as being toxic and expensive, alternatives need to be found for catalysts as well. Now, there is a lot of research going in at this level of research, and particularly one area that I'm particularly interested in is that of the use of ionic liquids as a soluble support for either the catalyst or the reagent, because at the end of a reaction, the catalyst and the reagents can be regenerated and reused, thus minimizing waste. So not only do you limit the amount of waste that is difficult to dispose of, you reduce your costs because you can reuse the reagents and the catalyst again. But this is a early stage research. But there's a whole field in chemistry now called green chemistry, and this is driving the innovation. AI also is playing a big role in terms of identifying candidates for medicine development. So it's just so much going on in this space, and that's only a tiny window.
Watching your enthusiasm makes me wish I had a bit more attention in my I remember my teacher calling my parents and saying, if she only tried, she would do quite well. In the garage there when I was a kid. Anyway, that's a completely different story. And so, Sam, on to you, the challenging factors for academics.
So I think there's I just want to add some context into it. Another study which we conducted during the COVID-19 pandemic, we have interviewed hospital staff based in the Royal Cornwall Hospital regarding the use of PPE and the plastic-related issues in general. And what we find is that the hospital was among the first to pilot the use of sterile melt machine to recycle and repurpose plastics such as surgical masks and tray wraps. However, little is known about the greenhouse gas emissions that the machine would add to the trust. And another finding that I think is worth to highlight is the over procurement of PPE at the start of the pandemic, which is somewhat understandable given this crazy pandemic that we had, but could have been prevented if we had a better structured system. Because this kind of oversupply had not only generated an excessive amount of plastic waste, but also led to significant energy consumption for storage and waste treatment. So I think the first challenge is we need to break out the current linear model and the ways of thinking, replace it with a more systematic mindset. Many times it's the system which drives our incentives. The systems right now are normally influenced by capitalism, where the essence is the perpetual economic growth and ever increase in production and consumption. The more we consume and produce, the more energy we will use, and it's really hard to foresee whether and when this new renewable energies can keep pace with this before it's too late. So to formulate such a system, what we need as academic is we need more data, and especially data from the industry, which at the moment is very unlimited. It's very limited, and it's usually unavailable. So that's a major challenge. I think we need to build an environment where the industry would feel more confident and comfortable to share their data, and we can have a kind of scheme that can protect them, so that a product's environmental impact at every stage of its life cycle can be evaluated and made public to inform policy and consumers.
I'd like to ask Tom about your app. You designed an app to calculate the CO2e of volatile anaesthesia. Where did you get the idea from? What are your findings? How's it all going?
Well, it's a lovely question. In anaesthesia, we're great measurers of blood pressure, heart rate, all sorts of physiological parameters. So I felt that if I devised an app that provided an answer, it might be well received. The problem, as was been alluded to so far, has been that there's this nebulous concept of the carbon dioxide equivalent. You can't see carbon dioxide, but we know it's going up. And it's very hard to conceptualize the equivalence of your carbon dioxide use from different agents. And so I just sat down and in the corner of the kitchen and started to define the mathematics that could convert something into something that would be useful. Now I say something, and that is because surprisingly in anesthesia, we dispense our volatile anesthetics, not in terms of milligrams or grams, but in terms of a percentage of the components of the gas mixture that's entering the lungs. Now, that's very different from the actual mass of the agent. And so the app had to convert a percentage of a flow into a mass. Once one knows the various physical laws, including the molecular weight, the mathematics are really pretty simple. And that's where it came from. And then to devise the actual app itself, I had the good fortune of working with a gentleman called Kevin Scott, who lives in Pembrokeshire in the west of Wales, and he helped me devise the interface that helped make it more appealing to anaesthetists.
I'm going to bring Lucy back in because she's dipped in and out a little bit, poor old Lucy. You haven't really heard a lot of the debate, Lucy, but I just wanted to ask you, what do we need from hospital leaders in the movement to decarbonise medicines? And is there a role potentially for non-consultant grade doctors, junior doctors, etc., to get involved and to help?
Thank you. So I think we've talked a bit about innovation, and I know that I've missed some of your discussion. Apologies again for that. But I think really we need leaders in hospitals who are champions for innovation and who cultivate a culture where it's okay to fail. Not all innovation is going to work, and that's something that is really challenging in the NHS. It goes very against the grain in terms of our culture that we usually work in. We need people who see the challenges we're facing as something that has to be addressed with urgency rather than an unaffordable luxury. People who will set ambitious goals for their organisations and encourage staff to collaborate, give them access to funding and tools, expertise to make these things happen. Sustainability needs to be seen by all of us, but particularly our leaders, as an absolutely essential work stream in every project that we do. And we need funding to facilitate the adoption of change. Even the greatest ideas don't spread themselves, and leaders need to be prepared not only to fund the innovation, but to budget for spending to facilitate long-term adoption of change. And as for non-consultant grade doctors, well, I'm a bit biased as a training myself, but definitely there's a role. Staff and associate specialists and specialty grade doctors are permanent members of staff. They're very embedded in their departments, and there's no reason why they can't have as big an impact as their consultant colleagues. And as for us specialty trainees, we're the consultants of tomorrow. We'll be the medical educators, the department leaders, the decision makers of the future. And we're also the prescribers of today. We work on the front line in the wards, clinics and theatres across the country. So I think we need to have a big focus on both postgraduate and undergraduate medical education so that we learn about the health impacts of climate change and ways that individual clinicians can make changes to their personal practice, particularly around prescribing, to have positive impact on the environment and to reduce their carbon footprint as an individual. So I think trainees need to be educated, but more importantly, empowered to make sustainable choices and to carry these with them as they progress through to their consultancy.
Lucy, thanks not only for the answer, but for carrying on presenting, because I dropped off the system for a little while there myself. Let's just have a little look at the questions that are coming in on the side of my screen. Tim says, given that, as you say, propofol is so much cleaner than any gas, why aren't anaesthetists using much more propofol-based TIVA? Mm-hmm. That sounds like it's potentially a question for you, Tom, is it?
Well, I think the answer is that anaesthetists are. Long operations are using TIVA, total intravenous anaesthesia, where the equipment exists. It has some considered benefits, and particularly in those very long procedures. And there is some evidence that it has beneficial effects for those patients who are having cancer surgery. Now, I haven't seen the latest evidence on that, so it mustn't be taken as gospel. But within my own department, the use of TIVA has risen very significantly.
Hannah says, how should the sector and pharmaceutical industry ensure that it commits to more sustainable choices post COP26? Marcia, is that something you could help with?
Yeah, so at the moment, I would say the pharmaceutical industry are addressing that. If you look at, for example, manufacturing, they're looking at the whole life cycle of producing medicines. So it's procurement of more materials, the chemical processes used, improved manufacturing processes and disposal. An example in terms of manufacturing is continuous manufacturing as opposed to the traditional batch processing. And this is has been shown to be far more efficient in terms of increasing the yield of active pharmaceutical ingredients, reducing waste, and producing a more consistent product. Also looking at packaging, how it's made, how it's disposed of, how it's used, right, reducing the size. So I would say there's a lot going on. But the other thing I think needs to happen as well is for pharma and the NHS to come together and work together to support the public. So, for example, you spoke earlier about the inhalers and the information Thomas mentioned about, supporting his patients in reducing their use of inhalers. I mean, if we could work, if pharma and NHS could work together on effective public information campaigns on the use and disposal of medicines, that would be really, really useful. Another thing I think is really important as well is that we've got to make it easier for patients and for the public to recycle and dispose of their unused medicine. But there's something else as well, which is important, is that there needs to be better dialogue between the medical profession and patients in terms of prescribing. When patients are diagnosed and there needs to be treatment, right, do they need to have the when they're prescribed drugs, how long do they need to take the drugs for? Right? Are there frequent engagement with the patients to review their treatment and review their progress? And does that need to be changed? So I think there's a lot around that space that needs to happen as well, in terms of appropriate prescribing. And sorry, and then there's another thing as well. Like, Marcia PCH did some research a couple of years ago in terms of adherence to medicines, and that is another important area. Patients are given medicines to take, but in some cases it can be about like less than 6% of patients are taking the medicines as prescribed. So, there's this work that needs to be done around there. So if they're not taking the medicines as prescribed, what's happening to those medicines? But also the patient's conditions could deteriorate, which means they need even more intervention, which is likely to mean they need even more medicine. So much around behavior that needs to be looked at as well.
You're so right. And also the public do want to help, don't they? They do want
They
to help
do.
their carbon footprint. So it's right to engage everybody in that. Just looking at another question that possibly, I don't know, Thomas, whether you feel you could answer this. Paul says, do you have any tips to help our organisations to move from an obsession with efficiency and using every penny well to a more experimental mindset where it is okay to fail?
So I think, like many trusts, our trust has a bit of an obsession with QI, quality improvement, but most people see that as a sort of a Trojan horse for money saving, whereas it should be more than that. And I think the idea of sustainable QI, quality improvement, allows it to move beyond that. And I think that to really engage with this process, like one of the other speakers was saying, the idea of trying things and allowing some to fail and others to succeed, and learning from both the failures and the successes is really important. So engagement with the quality improvement program and using it as a platform for sustainable QI, I think is what I'd encourage, as well as those other things that we've talked about: upward pressure on your leaders, horizontal pressure on your peers, and downward pressure on your own behaviours. I think all of those, because there's no silver bullet, of course, all of those are important parts of the answer.
Can I just say that as a researcher, there are more failures than successes, but you learn from the failures. And why we're so obsessed with getting everything right at the beginning when we're still learning? You just have to look at what's happened with COVID-19, right? And finding the vaccines. There's been so many things which, right, we've gone through in order to get to where we are. And leaders need to understand that you have to have failures in order to achieve success. So, I think that message needs to get out. Failure is not a dirty word.
Well, you can't have success really without failure, can you? And I'm sure that it's something that probably Sam will agree with. And Sam, in theory, what more can we What more can be done?
Yeah, I think just add to what the panelists they have said. I think patients are also aware of the environmental footprints or when they are using pharmaceuticals or surgeries, etc. So what I had in mind or throughout the years is similar to nutrition labels that the country had put years ago. Why not we also make a carbon or climate labels for products such as food and pharmaceuticals? And in that sense, it's a quick and a visual kind of information can provide to the users about climate footprint that they may intake when they are using these products or the procedures. So I think this is feasible to do and would play a significant role to increase environmental awareness and tackle climate change in the long run.
We've got 1 minute left, and that's 1 minute until Tom will be looking after his 11-month-old again. I hope somebody's looking after his 11-month-old right now.
My 11-month-old grandchild.
Yeah, we'll just make that clear, not
Heaven forfend.
Yes, actually, it did sound like you're 11-month-old. Started a bit later in life, Tom. But I was just going to end with the fact that, you've been environmental advisor at the Royal College of Anaesthetists for, I think it's about 8 years now. And I just wondered what you think is, as a collective, your greatest legacy, if you like.
When I think about this, I get rather a tingle. And I think without question, it's that I've inspired the generation, Lucy's generation, to think seriously about this issue. I know that when I stop doing this job, that sustainability will be at the heart of the Royal College of Anaesthetists and ingrained within inside those trainees and younger anaesthetists who will follow in my footsteps. And I thank the college for the opportunity they've given me, but I thank the generation that follow for taking the similar view to myself.
Very powerful words to end with. And I'd like to thank all of you, all of my panelists, for joining today. As I said this to you before we came on, but as a general news journalist, researching this subject, I found it extraordinary. And it just feels an honour to sit in all of your company. All of you would be very worthy keynote speakers, I'm sure, at another of our events. And I'm sure our audience have benefited from your expertise on our Decarbonising Medicines panel. So thank you very much.
Thank you.
Thank you.
Thank you.
Good
Thanks very much, everyone.
Good afternoon. It's time now for our final networking break of the day, and that means one last chance to engage with our speed networking functionality and to see if you're in with a chance to climb your way onto our leaderboard. I'm going to make a quick cup of tea, and I'll see you back here in 10 minutes' time.